Morning. Let's continue with our rheumatology session. The next speaker is Dr. Alexandra Villaforte. So she is a staff rheumatologist at Cleveland Clinic and is board certified in internal medicine and rheumatology, and she also has a master's degree in public health. So her main area of interest and professional role is in the diagnosis and treatment of vasculitis. Today we have requested her to talk about systemic autoimmune diseases. So let's welcome Dr. Villaforte.
Thank you. Good morning, everyone. Over the next hour or so, we're going to discuss some of the most important systemic autoimmune diseases in rheumatology. And these are systemic lupus erythematosus, systemic sclerosis, Sjogren's syndrome, and idiopathic inflammatory myopathies. Now, I'll try to highlight the most important points about each of these conditions through questions throughout the talk. So we'll start with case 1 of a 23-year-old woman who presents for evaluation of a facial and body rash, joint pain, fatigue, and recurrent oral ulcers. She was seen in the ER for those symptoms and treated for pain. On exam, she has a rash and Raynaud's, and you can see the rash depicted on the picture there on the patient's arm and forearm, and she has no joint swelling. So the most important initial test in the diagnostic evaluation of this patient is A, anti-double-strand DNA, B, a complete blood cell count with platelets, C, urine sediment and creatinine, D, ANA, and E, antiphospholipid antibodies. So please key to your answer. Okay, so this is an important question because we're going to need to address the results, and we'll do that over the next few minutes. The correct answer is actually C, urine sediment and creatinine. All the answers are correct, and in the real world in clinic, we're going to obtain all these tests. But the point that I'm trying to make, why is this the most important initial test, is because when you suspect someone has lupus, the first thing we need to evaluate for and rule out is that there's kidney involvement. So lupus is an inflammatory multi-system autoimmune disease that is associated with the presence of autoantibodies. It's the prototype autoimmune disease with multiple antibodies. They're associated with pathogenesis. It's of unknown etiology, and flares are very typical of this disease with relapsing remitting course present in about 70% of the patients. It's a lot more common in females than males, 10 to 1, and more common in women in reproductive age, 6 to 10-fold times. The pathogenesis SLE is quite complicated with the combination of genetic, environmental factors, and hormonal factors playing a role, with multiple abnormalities involving the innate and adaptive immune system seen in this disease, which primarily shows a failure to clear apoptotic cell debris. There are B and T cell abnormalities associated with lupus, and some of the examples that we see are autoantibodies production, circulating immunocomplex that can be pathogenic, complement activation, and therefore we see low C3 and C4 in these patients, and deposits of immunoglobulin, immunocomplex, and complement factors that result in tissue injury. Now, the diagnosis is primarily based on the clinical presentation, which is an evaluation that is done by detailed history and physical examination. And once there's a clinical suspicion for lupus, laboratory tests will further support the diagnosis. Important laboratory tests, but not limited to, are the complete blood cell count, since cytopenias are common, the kidney function, the urine sediment for evaluation of nephritis, ANA, which is an anti-nuclear antibody, anti-double-strand DNA, and complement primarily C3 and C4 components. Additional tests are guided by clinical presentation. For example, if someone presents with respiratory symptoms, they might need a CAT scan of their lungs. And tissue biopsies are sometimes necessary, for example, in the situation of skin rashes. The diagnostic challenges are many, but just to give some examples, patients may present with few manifestations at onset, and the disease might be very slowly evolving over a very long period of time, which makes the diagnosis not as obvious. Patients may present with intermittent signs and symptoms with periods of exacerbations and remissions, and sometimes it's not easy to catch at the time of activity. And there are many other multi-system diseases that may mimic lupus, since there are so many multiple organ involvement with this disease. We all know the American College of Rheumatology criteria for the classification of lupus, and they can be very handy to think about all the organ system involvement. And any combination of 4 or more of 11 criteria that are well documented at any time during a patient's history makes it likely that the patient has lupus. These are the specificity and sensitivity listed below. However, these criteria were developed for classification, not for diagnostic purposes, and they can fail the diagnosis of these patients. They were developed to guarantee patient comparability in research trials. That was the primary use. They're useful reminders, those of the features that are associated with lupus, and can be quite handy. But patients sometimes with early lupus may have only a few symptoms, not fulfilling all the criteria. It doesn't mean they don't have the diagnosis. The spectrum of clinical manifestations are beyond much greater than what those are outlined by the criteria. And the disease severity vary greatly among patients, and they're not measured by these criteria. The differential diagnosis is enormous. These are just some of the examples, and that's mainly because lupus can affect any organ system in the body. It is a very heterogeneous disease, which makes it a challenge for diagnosis. Ranges from very mild to severe or even life-threatening disease. But think about the most frequent manifestation, which are always going to be listed on these patients. They're very nonspecific, but a combination of constitutional symptoms, musculoskeletal symptoms, primarily joint and muscle pain, and mucocutaneous lesion or on-skin lesions are present in the majority of patients, but they may be mild at onset. Some of the skin lesions we associated with lupus are divided into acute, subacute, cutaneous lupus, and chronic lupus. So acute is the typical malar rash, for example. Subacute cutaneous lupus is a very typical and very specific type of lesion that is an annular polycyclic papillary squamous. I have a picture I'll show. And the chronic lupus is more associated with discoid lesions. Now, these are the ones that are more typically associated with lupus and makes us think about the diagnosis, but non-specific lesions can be seen, and there is a large variety of them. And Raynaud's phenomenon is present in more than 50% of the patients. Another combination of livedo reticularis and alopecia is also quite common in lupus. So this is an example on the left of the rash that can be raised, bumpy, and sometimes even associated with small ulcers and involve the nose and the malar area. On the other side, you have an example here of alopecia with thin and new hair growing that is called sometimes lupus hair. And this is the example of the typical annular polycyclic lesions that are seen in subacute cutaneous lupus. The diagnosis does not require skin biopsy. Can be done in the setting of other symptoms. This is an example of our ulcers. And talking a little bit about the musculoskeletal features, the typical presentation is just arthralgias, and when arthritis is present, it's typically not erosive, not destructive. A typical one seen with lupus is this clinical reversible deformity that's called Jacques arthropathy. They are actually subluxations and not true inflammation of the joint or arthritis. I'll show an example of that, a picture. And other complications affecting the joints that are associated with the disease itself or a complication from treatment are avascular necrosis of multiple joints. And that's not just seen on patients who are taking steroids, but it can be secondary to lupus itself. Septic arthritis can be seen on patients who are not immunosuppressed, just based on the risk associated with lupus, but it's more commonly seen on patients heavily immunosuppressed. Myositis can cause muscle pain and weakness, but is typical, not severe in lupus. This is what Jacques arthropathy looks like. It's not a consequence of erosive or destructive joint disease, but more of tendon and ligament subluxation. So when you look at the X-ray, you will not see the typical findings that are associated with rheumatoid arthritis. Another very common presenting symptom of lupus are when patients have serositis, and that can affect the lungs, the heart, or the abdomen with pleurisy, pericarditis, and peritonitis. Pleural effusions are very common, but they tend to be small. They are usually bilateral. And when there's a large pleural effusion, we need to exclude other causes, especially infection. An exudate is more commonly seen with lupus. Now, this is usually silent or associated with very mild symptoms when affecting the pleural and the pericardium area. Peritonitis, on the other hand, can be severe. Patients can present with acute abdominal pain requiring very large doses of steroids for control of the inflammation. They have anorexia, nausea, and vomiting, and the main differential diagnosis is bowel perforation or infectious peritonitis. Additional pulmonary involvement, not serositis, are commonly seen, and they're usually mild. Acute pneumonitis is the more common one, with clinically is very similar to a lung infection. Chronic interstitial disease or interstitial lung disease associated with lupus is not as common, but is important. Pulmonary hemorrhage is very rare, but it can be associated with the high risk of recurrence and high mortality. The last two, pulmonary hypertension, shrinking lung syndrome, are very rare, but worth mentioning here. Neuropsychiatric disorders are thought not to be common, but when we include headaches and mild cognitive dysfunction, they become quite common. These are some of the examples of how patients can present, for example, seizures, stroke, septic meningitis, transverse myelitis, and in the presence of any of the symptoms, lupus should be thought of. Headaches are difficult to understand and may be caused by different reasons, not just the lupus itself. So it's not usually used as an isolated item to determine whether the disease is active or not. Case 2 is of a 38-year-old female with a 10-year history of lupus that presented with serositis, rash, glomerulonephritis, seizures, and Raynaud's. She has a positive ANA and anti-double-strand DNA. She has a low C3 and C4, and she's been taking low-dose prednisone continuously for the last 5 years because of recurrent episodes of rash, joint pain, and oral ulcers. She presents to the ER with chest pain and dyspnea. Her blood pressure is 170/98 and heart rate 104. On exam, her lungs are clear. She has no pleural or pericardial ruptures. The most frequent cause of mortality in this patient is A, pulmonary hypertension, B, pleural effusion, C, myocardial infarction, D, Liebman-Sachs endocarditis, and E, myocarditis. Please key in your answer. All right, that is excellent because the correct answer is myocardial infarction. I want you to remember that the main point that I'm making on this case is a 10-year history of lupus, and that is associated with a high risk of cardiac disease. Heart involvement in lupus can affect any of the structures with pericarditis, myocarditis, endocarditis, which is well known and typically associated with lupus. However, the most important after 2 years of disease is premature accelerated atherosclerosis. Increased risk for premature atherosclerosis and cardiovascular disease is seen in lupus beyond the initial phase of the disease or the first 2 years. Cardiovascular death is the main cause of mortality in these patients. And many patients have subclinical atherosclerosis early in the disease course. Interesting as both the risk of coronary artery disease at any level of traditional cardiovascular risk factor, as well as the mortality from a cardiovascular event, is much higher in lupus patients as compared to the general population. The risk of cardiovascular disease is higher with longer duration of disease, and it may be aggravated by other risk factors that these patients are commonly exposed to, anticardiolipin antibodies and an impaired renal function. But most important point to make here is that lupus is an independent risk factor for cardiovascular disease. Now, hematologic abnormalities are very common with lupus, with all lines can be affected. Anemia, leukopenia, which is usually reflecting lymphopenia, can be seen. And some of the cytopenia, especially leukopenia and thrombocytopenia, may occur independently of active disease. In other words, they may be present when the patients are considered to be in remission. Interestingly, thrombocytopenia may be severe and refractory and associated with active lupus, or may be associated with antiphospholipid syndrome and TTP. And again, may occur independent of SLE activities. So it's not on itself a factor to be treated unless it's associated with active lupus. Other laboratory abnormalities that may help us to make this diagnosis or confirm a clinical suspected diagnosis is the anti-nuclear antibody. It's positive in over 98% of the patients, but very non-specific as they can be seen in healthy controls and other connective tissue diseases. And the percentage is shown there. The anti-double-strand DNA is in a way more helpful because it's more specific for lupus, but not as sensitive, and some large number of patients may not have it positive. In some patients, the titer of this test can correlate with disease activity, especially renal disease, but it doesn't happen to all patients, so it needs to be identified. The same is true for hypocomplementemia. Low C3 and C4 may be associated with disease flares, but that's not necessarily the case in all the patients. And a persistent and permanent low C4 can be seen even when patients are considered to be in remission. Other laboratory abnormalities, they're interesting to mention because those antibodies may be associated with the higher frequency of certain phenotypes. For example, the anti-double-strand DNA may be seen in more association with the presence of nephritis in about 70% of the patients. The anti-Smith antibody is not commonly seen because it's only seen in about 30% of the patients, but is the most specific antibody in lupus and is more associated with nephritis and central nervous system involvement. The anti-SSA is an interesting antibody. It's present in about 20 to 60% of patients, more associated with the subacute cutaneous type of lupus, but has also a risk of a fetus or congenital heart block, present in about 10% of the cases. The anticardiolipin should always be checked as it is associated with the higher risk of arterial and venous thrombosis, recurrent fetal loss, and commonly associated with the presence of thrombocytopenia. In the case 3, a 45-year-old female presents for follow-up of lupus. She has had increasing fatigue, but no other symptoms. Her urine sediment shows 1+ protein, no blood, no cellular cast, and her creatinine is 3.5. She has been on treatment with hydroxychloroquine and azathioprine. The lupus was diagnosed 5 years ago with glomerulonephritis, malar rash, pleurisy, and arthritis. ANA and anti-double-strand DNA were positive, and after treatment with prednisone and cyclophosphamide, her creatinine remained stable at 1.9 to 2.4. So you decide the best next step is to A, start prednisone and increase azathioprine to 150 milligrams to treat her glomerulonephritis recurrence. B, repeat the renal biopsy. C, start prednisone, stop the azathioprine, and start cyclophosphamide to treat her glomerulonephritis. D, get renal ultrasound for evaluation of chronicity of renal disease. Or E, start prednisone, stop azathioprine, and start mycophenolate mofetil to treat her glomerulonephritis. Please key in your answer. Okay, I guess they're very important questions because there are all options that have been chosen. The correct answer here is to repeat the renal biopsy, and I'll make a point and explain over the next few minutes why is this so important. It is an important question that comes up all the time about lupus is when do patients need another renal biopsy, if they ever do? This is a very clear case of a patient who is on treatment, has no symptoms to suggest active disease or relapse. Her creatinine is trending up without any evidence of blood in the urine and or cellular casts to suggest active nephritis. So basically, we don't know what's going on in her kidneys. She could be having early flare, but she could also just have fibrotic changes that result in chronic kidney disease. So the kidney biopsy is essential at this point. So lupus nephritis is a very important part of lupus, and clinical evidence of glomerulonephritis is seen at about 35% at time of diagnosis, or maybe even higher than that, but up to 60% of patients will have evidence of glomerulonephritis in the first 5 years of disease. Evidence of renal disease or suspicion for that comes from the presence of hematuria, cellular casts analyzed in the urine sediment, and proteinuria that is getting worse over time. The classification of lupus glomerulonephritis have not changed much. These are different histology that can be seen. With the most light one or the less severe one with minimal mesangial deposits, which usually does not require any treatment, mesangial proliferative, focal segmental, diffuse segmental, or membranous, which is a different type. Proteinuria level, and this is an important point, less than 0.7 to 0.8 grams per day at month 12 after onset of therapy is the best predictor of long-term kidney outcome. And this is an important point because it's so difficult to establish response to treatment in patients with lupus nephritis. Now, again, the role and timing of biopsy is very controversial, but there are times when it's clear that we need to do a biopsy. And those two times are the initial diagnosis. Patients, when suspected to have glomerulonephritis, needs a biopsy to guide treatment decision and also to allow us to have some idea about the prognosis. Because the biopsy gives us what's called activity and chronicity index based on histology. It can show us if lesions are active or if there's just chronic lesions, they're associated with the lower survival and increased risk of end-stage renal disease. Repeat biopsies sometimes are necessary throughout the course whenever we're contemplating a change in treatment and we're not sure about the histology, because different histologies may coexist and will affect treatment decision, because histology may change over time and disease recurrence sometimes is not obvious compared to just fibrotic tissue. Survival in lupus has improved significantly if we compare 1950s to 1990s, and the improved survival is related to earlier diagnosis, the availability of dialysis and renal transplant, and obviously more potent immunosuppressive agents. However, mortality rate is still 3 to 5 times greater than general population, and mainly because of cardiovascular disease. Causes of death are different in lupus depending on the stage of disease. Very early on the first 2 years of disease, is more commonly associated with severe lupus manifestations such as renal disease and central nervous system disease, as well as the infections because these patients are heavily immunosuppressed. But later on, and not too late, after about 2 years, disease damage and treatment toxicities start to happen more often. And cardiovascular becomes the main cause of death in these patients. Infections are still important because of immunosuppression. Now, treatment in lupus is really determined by organ involvement and disease severity, but we also taken into account at the moment that we are making a decision whether the disease is active or in remission, since it's a disease with intermittent relapses, individual factors such as age, because this disease often affects very young individuals that are at age of pregnancy, and also depending on the prognosis, for example, if there is glomerulonephritis or not. Treatment of mild disease is more towards symptoms with anti-inflammatory drugs, but hydroxychloroquine is a very important treatment for all the patients unless there is a contraindication, because it has been shown to prevent flares. Low-dose oral corticosteroids can be used for symptoms, and calcium channel blockers in the case of Raynaud's. For more moderate disease or more severe disease, there is escalation of immunosuppression and how aggressive the treatment is depending on the disease manifestations. Now, when it comes to nephritis, that's a little bit more complicated, but I'm trying to make this more clear with this slide. Either the patient has diffuse or focal nephritis, and the treatment has to be instituted very early to avoid chronic kidney dysfunction. The two main options are mycophenolate or cyclophosphamide. And the selection to use one or another depend on patient factors. One was not proven to be or shown to be more efficient than the other. Now, more recently, with new approvals of new medications, there's combination therapy that is more commonly used with mycophenolate. Given examples there, belimumab, voclosporin, and tacrolimus, and cyclophosphamide can be also combined with belimumab. Normally, if cyclophosphamide is chosen, there is an initial treatment of 3 to 6 months that is then switched because of the drug toxicity to mycophenolate mofetil or azathioprine. Mycophenolate mofetil is superior to azathioprine in preventing relapses of lupus nephritis, and sometimes in severe cases, a pulse of steroids with IV methylprednisolone a gram a day for 3 days may be needed. Now, there are 3 drugs that are approved by the FDA for the treatment of lupus. Belimumab had 2 approvals, one for mild to moderate disease in 2011, and in 2021 it was approved in combination with immunosuppressive therapy for nephritis. Voclosporin is a calcineurin inhibitor, and in January 2021, in combination with immunosuppressive therapy, was approved for lupus nephritis, not as a single therapy. And finally, anifrolumab is an anti-type 1 interferon receptor. So it's an antagonist and is used for moderate to severe lupus. They are receiving standard therapy. However, it's not been evaluated in severe lupus nephritis or severe central nervous system disease. So remember, first option for severe lupus nephritis will be either cyclophosphamide or mycophenolate mofetil, whether in combination or not. And we should not forget preventive care for these patients, such as osteoporosis, prophylactic immunization, aggressive control of risk factors of atherosclerosis, and if patients are heavily immunosuppressed, consider pneumocystis jirovecii pneumonia prophylaxis. A little word about drug-induced lupus is very similar to idiopathic lupus, but usually a milder disease that does not involve the kidneys or the central nervous system. Very common feature, the most common features are constitutional symptoms, arthralgias, rashes, or serositis. ANA is usually present in this patient, but anti-double-strand DNA is rarely seen. And interesting, antihistone is seen in about 95% of these patients. However, antihistone is not specific to drug-induced lupus and is also seen in native lupus. So it's not a diagnostic test. Usually this lupus resolves after discontinuation of the drug or needs just a low dose of corticosteroids. There are many drugs, over 100, that have been shown to induce lupus. These are the most common. We typically think of procainamide and hydralazine. Moving on to systemic sclerosis, this is a case of a 45-year-old female with a history of systemic sclerosis for 2 years who presents for a follow-up visit. Her blood pressure is 160/90. 1 month prior to this visit, she was diagnosed with myositis and was started on prednisone 40 milligrams a day. Her urine analysis shows 1+ protein, 1+ blood. She has no prior history of hypertension or renal insufficiency, and her baseline creatinine is 1.5. A week later, her blood pressure was now 180/102, and the creatinine is up to 2.1. She is hospitalized, and a renal biopsy reveals thrombotic microangiopathy. The best treatment approach at this time is start oral cyclophosphamide to treat her renal disease, or increase the dose of prednisone to 1 milligram per kilogram a day. Start intravenous nitroprusside for rapid reduction of blood pressure. Start intravenous immunoglobulin, or start angiotensin converting enzyme inhibitor for a gradual reduction of the blood pressure. Keenan, your answer. Okay, I think the diagnosis is very clear for renal crisis in a patient with systemic sclerosis. So the correct answer is start angiotensin converting enzyme inhibitor for gradual reduction of blood pressure. It's an extremely important point about this situation in this disease where immunosuppressive medications are not used to treat. And the blood pressure hopefully should be gradually decreased. And that's the first option. Systemic sclerosis is not a vasculitis. It's important to remember it's a vascular dysfunction disease with progressive fibrosis characterized by increased extracellular matrix production. It is typically manifested with cutaneous and visceral manifestations, has a high association with autoantibodies. ANA is positive in about 95% of the patients. Very typical Raynaud's phenomenon is present in a great majority of patients and is extremely rare in the general population. The main disease classification is based on the skin involvement by the disease. So when you read diffuse scleroderma or limited scleroderma, think of diffuse skin involvement or limited skin involvement. And there are some extra skin typical associations in each group. But diffuse scleroderma is defined by skin thickening affecting beyond the face and the distal extremities, involving typically the trunk and its proximal involvement, whereas limited scleroderma has limited skin thickening to distal to the elbows and knees and face, and is commonly associated with the acronym that we all know of CREST, calcinosis, Raynaud's, esophageal dysmotility, sclerodactyly, and telangiectasia. Now, the group of patients who present with serous scleroderma that are more difficult to diagnose is rare. These patients have no skin thickening, but characteristic internal organ involvement and serology that makes the diagnosis suspicious. These are examples of Raynaud's. On the side here, you have calcium deposits or calcinosis, and here is the consequence of Raynaud's with skin digit ulcerations. So in comparison to primary Raynaud's, these patients typically have Raynaud's that cause ulceration of the digits. So very important points at the diagnosis. Once scleroderma is suspected, this patient should be evaluated for the presence of interstitial lung disease and pulmonary hypertension. And that can be done with an echocardiogram and lung CT and pulmonary function test. All patients should be monitored for renal disease, and patients with any degree of gastrointestinal symptoms should be evaluated for GI involvement. Skin biopsy is not necessary for the diagnosis when it's typical, and the majority of patients has characteristic nail-foiled capillary changes that can be done in the office. And remember that scleroderma has a higher incidence of malignancy. Sometimes it can be a perineoplastic disease. Now, patients with diffuse skin involvement may have more severe disease, it can be life-threatening up to 20% of these patients. They typically have the anti-scleroderma 70 antibody, which is present in about 40% of the patients. Interstitial lung disease is more common in these patients, and it can result in a rapid decline in high mortality rates. And renal crisis, which is characterized by accelerated hypertension and renal failure. If a biopsy is done, that can show, as the case that I presented, microangiopathic hemolytic anemia and thrombocytopenia are commonly present. And corticosteroids, especially doses above 15 milligrams a day, is the major risk factor for the development of renal crisis in scleroderma. Patients with limited skin involvement, as mentioned before, have skin involvement distal to the elbows, knees. Pulmonary fibrosis is less likely in these patients. Doesn't mean it cannot happen, but pulmonary hypertension is a lot more frequent. So these are just frequency of different organ system involvement. And 60 to 70% of these patients have a different kind of antibody, which is the anti-centromere. So the diagnosis can be clinical if the patients present with the organ-specific manifestations. Now, these patients typically have severe GI symptoms, especially esophageal dysmotility. But they may present also with gastric antrovascular ectasia, which can have severe bleeding, not necessarily in great amount at one time, but slow. And small bowel dysmotility can result in malnutrition, diarrhea, whereas large bowel involvement is more commonly associated with constipation. The treatment of scleroderma as a general statement is based on organ involvement, and treatment is mainly directed to control of symptoms. For example, calcium channel blockers for Raynaud's, proton pump inhibitors for severe esophageal dysmotility, and ACE inhibitors for hypertension. Steroids should be avoided in these patients as much as possible or used at lower doses. When is immunosuppressive medications used in scleroderma? Some of the examples I listed here are important. Number one, interstitial lung disease, where mycophenolate mofetil, cyclophosphamide, tocilizumab, nintedanib, and rituximab can be used. Arthritis or myositis can be treated similar as rheumatoid arthritis with methotrexate, myocarditis with either cyclophosphamide or mycophenolate mofetil, and sometimes severe rapidly progressive skin involvement requires treatment, and attempts can be made with methotrexate or mycophenolate mofetil. Pulmonary hypertension has a set of drugs that are used for it, like prostacyclin-like drugs, endothelin receptor antagonists, and PDE5 inhibitors such as sildenafil, vardenafil, and tadalafil. Sometimes these patients need to be monitored in intensive care unit for the use of these drugs. There are 2 FDA-approved medications for systemic sclerosis-associated interstitial lung disease, but sometimes in addition to these 2, they're listed here, the nintedanib and the tocilizumab, cyclophosphamide and rituximab are also other options for the treatment of ILD in these patients. Important to mention are factors associated with poor prognosis in scleroderma, and these are diffuse and rapidly progressive skin involvement, the presence of tendon friction rub on physical exam, the presence of interstitial lung disease, and presence of myocarditis. Patients who have a higher risk of scleroderma renal crisis are those with rapidly progressive skin disease, and also the presence of an anti-RNA polymerase 3. Moving on to Sjogren's syndrome. This is a chronic multi-system inflammatory disease affecting primarily the exocrine glands, but also affect an extragland number of organs. It typically causes lymphocytic infiltration that results in chronic lymphocytic sialadenitis. So most typical of this syndrome is the exocrine, but also extraglandular manifestations will be discussed here. These patients have a high frequency of rheumatoid factor, anti-SSA, and anti-SSB antibodies. It's more common in female and more common in older females in the 4th and 5th decades. It can present as a primary syndrome when does not have an associated underlying condition, or a secondary syndrome when the Sjogren's is secondary to rheumatoid arthritis, for example, lupus or scleroderma. So part of these other conditions. The typical clinical features of Sjogren's syndrome are the dry eyes and dry mouth. Keratoconjunctivitis conjunctivitis causes burning, sandy or scratchy sensation, photosensitivity, and redness of the eyes, and can result in corneal erosions. It's an important and chronic problem, difficult to treat in some patients. Severe dry mouth can result in difficulty swallowing or speaking, a loss of taste, burning sensation of the mouth, and very frequent dental caries. Parotid and major salivary enlargement are present in the majority of patients, approximately 60%, and the parotid enlargement is usually bilateral, which is important when thinking about your differential diagnosis. Extraglandular manifestations from Sjogren's are common. The most common ones are joint pain. When arthritis is present, it's usually non-erosive, so not similar to what we see with the rheumatoid arthritis, but non-erosive, non-deforming, and non-damaging arthritis. Fatigue is common and present in almost all patients. Raynaud's phenomenon is also common, usually not associated with fingertip ulcers. Lymphadenopathy is present in a good number of patients, and interstitial lung disease can be seen. Renal involvement is not common, but typically is of a distal tubular acidosis. That's just an important point to remember since it's frequently seen in questions. Other manifestations that can be associated with Sjogren's include primary biliary cholangitis, myositis, which tends to be mild in the majority of patients. Rarely we see vasculitis, which is more commonly affecting the skin. And peripheral neuropathy can be seen in two different ways. Patients can present with a small fiber neuropathy or a true vasculitic neuropathy, but those are very rare. The differential diagnosis depends on the symptoms. If we're thinking about, for example, xerostomia, we have to think of certain medications that can cause a lot of dry mouth, IgG4-related disease, viral infections, hepatitis C, and psychogenic dry mouth. Sarcoidosis, salivary gland tumors, bacterial infections, certain viral infections such as HIV can cause parotid enlargement and TB as well. I want to add to the second list also IgG4-related disease, which is actually a disease that can very frequently lead to bilateral parotid enlargement. Sjogren's patients have an increased risk of hypergammaglobulinemia. It can be a polyclonal or a monoclonal gammopathy, and these patients are also at a higher risk and have a higher frequency of lymphoma. So those are the things that have to be entertained when evaluating a patient with, for example, lymphadenopathy. And finally, the idiopathic inflammatory myopathies. This is a very interesting group of diseases. They're multi-system, they're autoimmune, and they affect primarily the skeletal muscle, causing weakness, which is the main feature of this disease. They have a totally separate setting of autoantibodies called the myositis-specific autoantibodies, which we'll talk a little bit about it. They're extremely rare and more common in females. There are many different classifications. This is just one example. There is a lot of controversy regarding this classification. Some of the experts do not even include polymyositis anymore, which is controversial because it would require a muscle biopsy in all patients to determine their classification. But traditionally, we think of this disease as either polymyositis, dermatomyositis, the antisynthetase syndrome, and the immune-mediated necrotizing myopathy, those being the most important inflammatory myopathies, but also let's not forget of the inclusion body myositis in the older patients, myositis they're associated with malignancy, myositis they're associated with other connective tissue disease such as scleroderma and childhood myositis. These are progressive, usually painless, very symmetrical proximal muscle weakness that in the majority of cases are slowly to progress. Sometimes, occasionally, patients may complain of muscle pain, but these are usually very mild, and sometimes the pain is more localized to the joints. Typically, patients present with fatigue, fever, weight loss that can be quite severe and sometimes suggestive of a malignancy. The skin rash in dermatomyositis may proceed, may develop at the same time or after the presence of myopathy. And some patients might not have any myopathy and have dermatomyositis with skin involvement only. These are typical skin lesions that can be seen with dermatomyositis, but I'd like to mention here that sometimes we see very nonspecific rashes. But these are the rashes that in a case presentation would be mentioned in association with dermatomyositis. So it's important to be familiar with Gottron's papules, the heliotrope rash, malar rash that is similar to lupus, the V sign, as you can see there, the Shaw sign, which is on the back. These patients have severe photosensitivity and cuticular overgrowth. Mechanic hands is seen in antisynthetase syndromes and calcinosis cutis that is more common in children. This is an example of the heliotrope with periorbital swelling. So these are purplish, dark red rashes around the eyes. And in this case here, I want to point to the severe swelling that you see on both superior eyelids. So they're very common with these rashes. Other organ or extramuscular involvement in inflammatory myopathies are actually common. Patients may present with just arthralgias or true inflammatory polyarthritis, although erosive arthritis is not common. Raynaud's lung involvement, which can manifest as interstitial lung disease or respiratory muscle weakness, or aspiration pneumonia that comes from pharyngeal muscle dysmotility. So it's important to evaluate what exactly is going on in the lungs, how is the lungs being affected, as the treatment will be different. Cardiac involvement is actually common, but usually asymptomatic. The majority of patients do not complain, and sometimes this is an incidental finding. Myocarditis is also a focal process similar to what is seen in skeletal muscle. The myositis-specific autoantibodies are a very interesting specific group of autoantibodies that are usually associated with different phenotypes of myositis. They are not necessary for the diagnosis, especially when they're only seen in 20 to 40% of the patients, but they're helpful in a way to determine a little bit more specific phenotypes as well as prognosis that may be associated with its presence. To give you some of the examples, there are many more. Anti-Jo1 is typically associated with an anti-synthetase syndrome that presents with interstitial lung disease, fever, inflammatory polyarthritis, Raynaud's phenomenon, and mechanics hands, and can be a very rapidly progressive, quite severe disease. Important to be recognized clinically because these antibodies may take up to 3 weeks or sometimes 4 weeks to return the results. Anti-SRP is more associated with severe myopathy, so it's an important one when it comes to prognosis, and more associated with immune-mediated necrotizing myopathy, which is a specific type of inflammatory myopathy that I'll discuss a little bit. The anti-ME2 is associated with classic dermatomyositis and also has a prognosis of more severe disease. The diagnosis of myositis has to come first from its clinical presentation. So when patients present with symmetrical proximal weakness, this should be suspected. The characteristic rash, when it present, raises the suspicion for dermatomyositis, and a biopsy is not always necessary to make the diagnosis if clinically the patient presents very typically. These patients have an increased CK associated with the muscle weakness. The EMG test is very nonspecific. However, it helps when there's not a clear picture in physical exam whether the weakness is coming from neuropathy or from myopathy. So that in that way, the EMG is helpful. But a muscle biopsy is the definitive test when necessary. It shows focal inflammation, degeneration, regeneration of muscle cells, atrophy of muscle cells, and later in the stage of disease, replacement of muscle by fibrosis and fat. It's particularly different in immune-mediated necrotizing myopathy, which shows a lot less inflammation and severe necrosis as compared to polymyositis, and in inclusion body myositis. So those are two of the phenotypes of the different subsets of inflammatory myopathies where the muscle biopsy can be very helpful. An MRI is a test that is non-specific but may improve biopsy yield when we look into an area of the muscle that might be more affected. And it can also help distinguish in end-stage damage when patients are getting weaker, but it's not clear on the clinical assessment if the worst weakness is from a flare or worse active disease as opposed to fat replacement of muscle or end-stage disease when increasing immunosuppression would not be helpful for this patient. ANA is present in the majority of patients. And again, just to give an example on how nonspecific this test can be. A word about immune-mediated necrotizing myopathy is an important subset of these diseases. Typically thought to be associated with use of statins, but is not exclusive. And even on patients with a positive HMG coenzyme A reductase antibody, the use of statin is not necessary. So a subset of patients may have a positive antibody, biopsy-proven immune-mediated necrotizing myopathy, and were not exposed to statins. These patients present with bilateral proximal severe muscle weakness, a very high CK, a rapidly progressive disease, and the muscle biopsy shows extensive necrosis and paucity of inflammation when compared to polymyositis. It's important to remember that myositis can be associated with malignancy, and the greater risk of that is with dermatomyositis. Many different types of cancers can be present, most commonly ovarian, lung, pancreatic, stomach, colorectal, or non-Hodgkin lymphoma. Overall, the risk is greatest in the first 3 years after the diagnosis of myositis. The majority of these patients that have myositis-associated malignancy, the malignancy presents within the first or the second year after the diagnosis of myositis. So within a year of the diagnosis, before or after. And of course, older patients are at greater risk. So we always ask ourselves, who are these patients who should be screened for malignancy once the myositis diagnosis is made? And what kind of screening should be done? At the present moment, the recommendations is that in young patients, the screening should be what's the age-appropriate recommendations for the general populations. But in older patients, one may consider, for example, a CAT scan of the chest and abdomen pelvis, in addition to the age-appropriate screening. The treatment of myositis depends on the clinical phenotype or presentation and how aggressive and severe the disease is. Patients may present with two different courses of disease, one of exacerbations and remissions with frequent flares, or, as the majority of patients, a persistent chronic progressive active disease. These patients typically require very prolonged use of very high dose of corticosteroids, so it is advisable to consider the simultaneous use of a second immunosuppressive agent once the corticosteroids are started at the time of diagnosis. Some of these agents that can be considered in combination with corticosteroids are methotrexate, azathioprine, mycophenolate mofetil, or tacrolimus. But in more resistant or severe disease, IVIG is the first option, as it's been approved by the FDA in 2021. IVIG is commonly used, and great response is seen even on severe disease. Other options for this group of patients are rituximab and cyclophosphamide. It's important to consider when thinking about treatment options, what are the extramuscular involvement these patients may present with. Some of these patients may present with severe interstitial lung disease where methotrexate should be avoided, and cyclophosphamide or mycophenolate mofetil would be first options. So depending on the extramuscular disease and the severity of its presentation, some of these drugs would be favored. And I thank you for your attention.
Thank you, Dr. Villaforte. That was excellent. So the next speaker is Dr. Carol Langford. She's the director of the Cleveland Clinic Center for Vasculitis Care and Research within the Department of Rheumatic and Immunologic Diseases. She's a professor of medicine at the Cleveland Clinic Lerner College of Medicine of Case Western Reserve University, and is also the vice chair of rheumatology for research. As of 2011, she is the Harold C. Schott Professor of Rheumatic and Immunologic Diseases. Her talk will be presented virtually. It's a pre-recorded talk. So without further ado, let's welcome Dr. Langford. She'll be talking about systemic vasculitis.
Hello, I'm Carol Langford. I'm pleased to be here with you today to discuss the topic of systemic vasculitis. Now, many of you may have wondered why an hour of your time is being devoted to what are rare diseases. And there's really several reasons. One is that in many ways, these are prototypic illnesses in the practice of internal medicine that present us with tremendous diagnostic and therapeutic challenges. Another important reason is that these patients don't present first to me. They're seen first by all of you, and it is really through your vigilance in recognizing these that you can have potential differences for organ and life-threatening therapeutics to be initiated. And then the final reason is because of their multi-system nature. This makes this a very keen topic, potentially for board examination questions. So let's begin then. So what actually is vasculitis? Is it A, a specific disease entity, B, inflammation of the blood vessel, C, a blood vessel neoplasm, D, arterial calcification, or E, a term synonymous with aneurysm? All right, so vasculitis is inflammation of the blood vessel. And as we'll talk about, this represents multiple disease entities in which aneurysms can occur, but there are also other vascular features as well. So vasculitis represents inflammation of the blood vessel. And when this occurs, blood vessel damage can occur, which can lead to one of two different pathways. Compromise of the vessel lumen, where there is resultant organ ischemia or infarction, or thinning or attenuation of the vessel wall, which can lead to formation of an aneurysm, or when the vessel is small, hemorrhage into the surrounding tissue. One of the best examples is that of cutaneous vasculitis, where we can see a tremendous matching of the histologic and clinical features. On the left, we can see cutaneous vasculitis, where we have the epidermal surface on the top, and below those two small blood vessels, which are almost unrecognizable. These have areas of inflammation and extravasated red blood cells, and this is what we can appreciate when we look at the extremity on the right, where we have an example of palpable purpura. Were you to run your finger over the skin, these lesions would not blanch, and this represents the fact that these red blood cells are no longer in the vessel, but are in the surrounding tissue. Vasculitis, as mentioned, is not one specific disease, and blood vessel inflammation can be seen in a variety of settings. We can think of this broadly in two categories. Secondary vasculitis, where the vasculitis is occurring secondary to an underlying disease or exposure, and this can occur in the settings such as with medications, infections, malignancies, a patient with a transplant, cryoglobulinemia, and with other immunologic diseases. On the other hand, there are primary vasculitides that are unique disease entities that are without a currently identified underlying cause, and where vasculitis forms the pathological basis of tissue injury. And it is here that we will be having our focus today. How can we tell these primary forms of vasculitis apart, and how do they differ? Well, there may be differences in terms of the age of the patient, sex distribution, ethnicity, and frequency. Clinical manifestations such as the patient's symptoms and signs, and in particular patterns of organ involvement, play an important role in differentiating these diseases. This then in turn influences how we might approach the diagnostic process, which may range from performing a tissue biopsy, arteriography, or there may be rare instances where clinical features and laboratory abnormalities are sufficient to be able to make the diagnosis. And this in turn then will influence our treatment decisions and the patient's outcome, which can range anywhere from supportive care with monitoring all the way up to rapid need for initiation of aggressive immunosuppression, usually with glucocorticoids and another immunosuppressive agent. Now, we're going to be thinking about these diseases today in terms of these different categories. Now, one other way that these can be differentiated is on the predominant size of blood vessel that's affected. So when we look at the vascular tree, ranging from the largest blood vessel with the aorta all the way out the other end to the capillaries and the veins, We can see that these can be differed in terms of the forms of vasculitis in which these occur. Our large vessel vasculitis would represent giant cell arteritis and Takayasu arteritis. Medium vessel vasculitis would include polyarteritis nodosa and Kawasaki disease, which almost exclusively affects children. And then the broadest range, which is our small vessel vasculitis, which include granulomatosis with polyangiitis, microscopic polyangiitis, eosinophilic granulomatosis with polyangiitis, Church-Strauss, and IgA vasculitis, Enoch-Schönlein. Now, vessel size also plays a role in the symptoms and signs that the patient may present with. So when we think about these features, when the carotid artery is affected, the patient may present with features such as a TIA or stroke. Arm claudication may occur when there's involvement of the subclavian artery, and renal artery involvement can include hypertension. With the medium vessels, when the digital artery is affected, we may see a blue ischemic vision. There may be a mesenteric artery involvement, which presents with bowel infarction. And when the epidural arteries are affected, patients may present with a mononeuritis multiplex, such as a wrist or foot drop. With the small vessels, again, we saw previously about cutaneous vasculitis presenting as palpable purpura. The kidney would be glomerulonephritis. And in terms of the lung, this can manifest as pulmonary hemorrhage. So this is why we can see both a wide range of severity that occurs within vasculitis and also the wide range of presentations that our patients may have. So here's our first case. This is a 75-year-old female who presents to your clinic with a 3-month history of aching in the muscles around her shoulders and hips. For the past month, she has had headaches and jaw pain when chewing meat. Her labs are notable for a sedimentation rate of 92 and a hemoglobin of 10.0, and you begin prednisone 10 milligrams daily. So which of the following is this patient most at risk of developing? A, acute renal failure, B, visual loss, C, prednisone toxicity, D, stroke, or E, thoracic aortic aneurysm. And the answer I was looking for here is prednisone toxicity. Now, many of you may have selected B, vision loss, as you accurately felt that this patient had giant cell arteritis, in which the most concerning feature is that of permanent blindness. And while this occurs in 14% of patients, prednisone toxicity can occur in up to 86%. The purpose of this question was not only for you to recognize the potential complications of glucocorticoids, but also to serve as a reminder that when you're in the board examinations, read the question closely and look for things such as comments like most or often in thinking about how this reflects upon the answer choices. So giant cell arteritis, historically also called temporal arteritis, is the most common form of systemic vasculitis that affects us as people. This is a granulomatous large vessel vasculitis that preferentially affects the extracranial branches of the carotid artery. It occurs in people over the age of 50, predominantly people in their 70s, and this mostly affects women in a ratio of 2 to 1. Giant cell arteritis is best thought of in terms of its 4 distinct phenotypes. Cranial disease, as we've discussed, polymyalgia rheumatica, which is an aching along the shoulder or hip girdle, features of a systemic inflammatory disease, potentially large vessel involvement. And many of these patients will have features that can occur together. They may occur sequentially, or they may occur separated by many years in time. Cranial disease is the phenotype most readily associated with giant cell arteritis, and are disease features due to vasculitic involvement of the external and/or internal carotid artery branches. The features can include headache, jaw or tongue claudication, and temporal artery tenderness. The most dreaded clinical manifestations of cranial disease are cranial ischemic complications, which represent tissue infarction due to vessel occlusion. As was alluded to in the case, vision loss can occur in up to 14% in rheumatology-based literature, Not surprisingly, this is higher in the ophthalmology series, stroke, tongue ischemia, or scalp ischemia. Large vessel disease can occur in up to 1/3 of these patients, and some of the more prominent manifestations can include subclavian artery stenosis, which can occur in 1 out of every 8 patients. And of greatest concern is the development of thoracic aortic aneurysms, which can occur in 1 out of every 5. This can occur as a late manifestation of disease and can also be associated with mortality. Giant cell arteritis can be suggested by its compatible age, symptoms, and signs, together with an elevated sedimentation rate and/or C-reactive protein. The diagnosis can be established by a temporal artery biopsy, in which we see panmural mononuclear cell infiltration, disruption of the internal elastic lamina and giant cells, but the challenge remains this may be positive in only 30 to 70% of patients. Ultrasound can also provide a useful frame of reference in approaching the diagnosis of these patients. The treatment of giant cell arteritis forms the foundation with glucocorticoids, in which prednisone 40 to 60 milligrams a day is used at initiation. There's been compelling evidence that prednisone reduces symptoms and, very importantly, prevents visual loss. And for this reason, prednisone should be started immediately in patients where there's a concern for giant cell arteritis, or the biopsy or other diagnostics are being arranged. Prednisone treatment may be required for 2 years or more. And because of the toxicity, there has also been data with the use of the IL-6 receptor antagonist, tocilizumab, which can be given subcutaneously or intravenously. This can be found a benefit from a randomized trial and is FDA approved for giant cell arteritis in combination with prednisone. It is not a replacement for prednisone, and its use is individually based. The acute mortality risk, such as from stroke or myocardial infarction in giant cell arteritis, is uncommon, but as noted, there may be late mortality from thoracic aortic aneurysms. Relapses requiring an increase in prednisone dose occur in about 75% of these patients, and prednisone-related toxicity, again, can occur in about 35 to 86% of patients, representing causes of morbidity and also potentially mortality. So let's go on to another case. This is a 26-year-old woman with Takayasu arteritis who comes to your clinic to establish care. In reflecting on factors that could impact her future outcome, which of the following is the most frequent cause of morbidity in patients with Takayasu arteritis? Is it A, myocardial infarction, B, stroke, C, hypertension, D, renal failure, or E, bowel ischemia? And the answer I was looking for here was hypertension. Now, all of these actually can unfortunately occur in patients with Takayasu arteritis, but one of the main risk factors for all of their occurrence is hypertension, which can occur in a very high percentage of these patients, as we'll discuss. Takayasu arteritis is a granulomatous vasculitis that affects the aorta, its branches, and the pulmonary arteries. This predominantly affects women of childbearing age, and although it is associated with Eastern ethnicity, it is very much seen internationally. Takayasu arteritis can present with either systemic or vascular symptoms. Systemic symptoms may be present, but also may be absent in up to 80% of patients. This can include fatigue and malaise, weight loss, fever, and pain in the joints and muscles. Vascular symptoms are related to vascular stenoses and aneurysms, and some of the more common features may include extremity claudication, TIAs and strokes, visual changes, myocardial infarction, or congestive heart failure. On physical examination, we may note the presence of vascular bruise, asymmetry of the blood pressure between extremities, an absence of pulses, features of valvular regurgitation, tenderness of the great vessels, of which carotidinea is quite a common feature, and hypertension may be seen in 35 to 93%, as was the issue with our case. Now, Takayasu arteritis is really diagnosed by vascular findings on arteriography. This is most commonly performed nowadays by computed tomography or magnetic resonance imaging, in which it is important to visualize the total aorta and major branches, both for diagnostic and also in following the patient and having an accurate baseline. Treatment of Takaysu arteritis, the initial treatment is typically that of glucocorticoids with prednisone, used either alone or with another conventional agent, such as methotrexate or azathioprine. For persistent or severe disease, there has been data with the use of TNF inhibitors or IL-6 antagonists. Non-medical therapy plays an important role for fixed vascular lesions producing extremity ischemia, and this may include surgery or angioplasty, particularly in settings of cerebral hypoperfusion, limb claudication, which is affecting quality of life, aneurysm repair, vascular insufficiency, or renal vascular hypertension, which is not responding to medical therapy or where there are features of renal insufficiency. Takaysu arteritis has an 83% 15-year survival, but it is very much a chronic disease in which 45% of patients relapse and 23% may never achieve a satisfactory remission regardless of therapy. Here then is another case. This is a 35-year-old man who comes to the emergency room with a severe headache. He has a 1-month history of fatigue and a 1-week history of headaches and night sweats. On examination, his temperature is 36.5. He has a blood pressure of 220/130, which is reproducible, and a pulse of 80. He is unable to move his left first toe, which is new. An arteriogram is done to investigate his hypertension, and you can see these images here. So which of the following diagnoses would explain his clinical and radiologic features? A, primary hypertension, B, fibromuscular dysplasia, C, polyarteritis nodosa, D, renal artery stenosis, or E, antiglomerular basement membrane disease. And the answer I was looking for here was polyarteritis nodosa. Now, all of these have reference to the renal vasculature. And on the last slide, we were shown a picture of a renal arteriogram. And the real question is, where was this vascular abnormality occurring? And it was in the medium-sized vessel of the kidney. So fibromuscular dysplasia and renal artery stenosis tend to affect the large vessel, typically the renal artery. And antiglomerular basement membrane disease affects the glomerulus, the smallest vessel. So the only vessel here that would affect the medium-sized vessel is polyarteritis nodosa. Now, polyarteritis nodosa is important in that it was the first form of non-infectious vasculitis described in the mid-1800s, and has since gone through a number of changes in nomenclature. The most significant of which occurred in 1994 when polyarteritis nodosa was broken apart from microscopic polyangiitis, now recognized to be a small vessel disease. Polyarteritis nodosa is now defined as a disease infecting the medium-sized vessels, where we say no lung involvement, no glomerular involvement. This disease is not associated with ANCA, and relapses are relatively uncommon. Polyarteritis nodosa often presents very acutely, as did this patient. There may be constitutional features such as fever, weight loss, arthralgias, and night sweats. Mononeuritis of the nerve can occur, and this patient had a toe drop, which was new. They can also have significant hypertension, which this patient has, and this was a reflection of the renal interarcuate artery medium vessel involvement. There can also be infarction, and again, a reminder that this is not a glomerulonephritis. Now, gastrointestinal tract involvement can represent one of the most important factors in terms of morbidity and mortality, and it can occur with pain, infarction, perforation, or bleeding. We can also see heart and digital infarctions as well. Arteriogram, which is typically a catheter-directed study, which is necessary to visualize the medium-sized vessel, can be useful in patients where you're seeing features such as symptoms or signs involving the viscera or the renal circulation. And what we see here are stenoses, beating, or microaneurysms. Biopsy may also be considered if there is a significant site that may be affected. And here we see a biopsy of a sural nerve where we see necrotizing inflammation of the medium or small arteries with abundant neutrophil and fibrinoid changes. The treatment of polyarteritis nodosa is based upon its severity, where prednisone and cyclophosphamide would be initiated for life-threatening disease, and rare instances of non-severe disease may be treated with prednisone alone. It should also be recognized that a PAN-like vasculitis can occur in association with hepatitis B or C, where antiviral therapy plays a central and important role, and immunosuppressive therapy is only used as necessary to control the vasculitis. Polyarteritis nodosa has an 80% estimated 5-year survival with treatment, and relapses occur in less than 20%. Now, this next patient is a 55-year-old woman who presents to your clinic with a past history of polyarteritis nodosa for which she was treated with prednisone and daily cyclophosphamide. She has been off all medications for 10 years and has remained in remission since that time. So which of the following malignancies is she at increased risk of developing as a result of her past treatment? Would it be A, ovarian cancer, B, melanoma, C, bladder cancer, D, colon cancer, or E, she is at no increased risk because of the duration that she has been off of treatment? So the answer I was looking for here was bladder cancer. Although you may not be commonly prescribing cyclophosphamide, you may see patients who have received this. Therefore, recognizing its toxicities is important. Bladder cancer represents one of the side effects that can occur with cyclophosphamide exposure. And this can occur at any point, even following treatment discontinuation, such that the risk of bladder cancer should be considered lifelong. So the fact that she has been off it for 10 years is not a factor here in considering this risk. Cyclophosphamide is a life-saving drug in severe systemic vasculitis, but it does have toxicities. Acutely, these can concern infection, bone marrow suppression, and the risk of bladder injury with hemorrhagic cystitis. And the long-term toxicities include infertility in both men and women and the risk of malignancy. This includes transitional cell carcinoma of the bladder, which we discussed, a blood element cancer such as leukemia and lymphoma, and an increased risk of skin cancer. The cancer risk and need for monitoring should be considered lifelong, and in a patient who has new hematuria in the setting of disease quiescence, you should think about bladder toxicity and perform cystoscopy. This next patient is a 45-year-old female who presents to your clinic with a 9-month history of nasal congestion and epistaxis that has worsened despite antibiotics and nasal steroids. She adamantly denies nasal drug use. Examination reveals a large nasal septal perforation, and the mucosa appears ulcerated and inflamed. On her labs, her white blood cell count is 12,000, hemoglobin of 10, platelets of 435,000. Her sedimentation rate is 70, creatinine is 1.3, and her urinalysis reveals 2+ protein with 10 to 20 red blood cells. And we can see here her chest radiograph. This patient's clinical features are most suggestive of which of the following diagnoses? A, granulomatosis with polyangiitis, B, relapsing polychondritis, C, mycobacterium tuberculosis, D, surreptitious cocaine abuse, or E, eosinophilic granulomatosis with polyangiitis Church-Strauss. And the answer I was looking for here was granulomatosis with polyangiitis. Now, relapsing polychondritis, mycobacterium tuberculosis, and surreptitious cocaine abuse can all be associated with the nasal septal perforation that was noted in this patient. However, she also had features of a lung infiltrate as seen on the chest x-ray and microscopic hematuria, neither of which would typically be seen in these clinical features. Now, eosinophilic granulomatosis with polyangiitis, as we'll discuss, is another form of vasculitis, which could potentially have renal and pulmonary features, but we were not given any history of asthma, which is common in that disease, and the nasal septal perforation would also be unusual in this disease setting. Granulomatosis with polyangiitis, formerly called Wegener's granulomatosis, is a vasculitis affecting the small to medium-sized vessels associated with granulomatous inflammation of the respiratory tract. This typically affects adults between the ages of 40 to 60, but it can be seen at all ages. It occurs equally between women and men and affects about 3 out of 100,000 people. Granulomatosis with polyangiitis affects the sinus and upper airways in about 95+% of these patients. This is something we can appreciate in the office when we examine the nasal membranes, and we'll typically see ulceration and cobblestoning. By computed tomography, as seen on the right, we can see thickening of the sinus mucosa, here involving the maxillary, sphenoid, and ethmoid sinuses. And when this occurs, there can be loss of blood supply to the cartilaginous portion of the nasal septum, which can lead to septal perforations, as was seen in our case, or also collapse of the cartilaginous portion of the nasal bridge, as is seen on the left. The lung is the second most common site of involvement, affected about 85% of these patients. We can really see just about any radiographic pattern. The most common is what is seen on the top, which is where we see bilateral nodules or infiltrates. On the left, we can see cavitary lesions, which can occur in isolation or multiple in isolation, raising concern for infection. And then on the right, the most immediately life-threatening, which are these ground glass infiltrates, which are present in the setting of pulmonary hemorrhage. The kidney is the third most common site of involvement, and although 80% will have glomerulonephritis during their disease course, only about 20% will have this at the time of their presentation. This is of concern as it can rapidly progress to renal failure and is detected by our vigilance in examining the urinalysis for evidence of proteinuria, but more significantly, hematuria or red blood cell casts. Granulomatosis with polyangiitis, while again should be thought of when we see features of the sinus, lung, and kidney, is very much a multi-system disease, though, in which we can see prominent involvement of the joint, skin, eye, nerve, and many other organs. This case is of a 33-year-old female who presents with progressive nasal congestion, fever, and cough, and her evaluation is notable for nasal mucosa appearing ulcerated and bleeding. She has mild anemia, an increased sedimentation rate, and C-reactive protein. Her urinalysis is negative for protein or blood. Her CT sinuses shows mucosal thickening of the bilateral maxillary and ethmoid sinuses. Computed tomography of the chest shows 2 nodules that are 2 by 2 centimeters, one of which is cavitary, and she has a positive proteinase 3 or PR3C ANCA. So a biopsy of which of the following would provide the highest diagnostic yield for granulomatosis with polyangiitis? A, sinus, B, transbronchial lung biopsy, C, surgical lung biopsy, D, kidney biopsy, or E, no biopsy is indicated as her ANCA is positive. So the answer I was looking for here was a surgical lung biopsy. So a sinus biopsy, while being relatively less invasive, has a very low yield for diagnosis. Transbronchial, while being less invasive, again, has a positive yield of less than 10%. We were not given any features to suggest kidney involvement. Therefore, a kidney biopsy would not be something to pursue in this patient. And as we'll talk about, the ANCA is not always the most reliable test. So again, if we are trying to differentiate between infection, neoplasm, or vasculitis, a surgical lung biopsy would have the highest yield. So this really raises the question about the utility of this diagnostic test of anti-neutrophil cytoplasmic antibodies, or ANCA. This has two immunofluorescent staining patterns: a diffuse cytoplasmic staining pattern, which is associated with the target antigen of proteinase 3, and a perinuclear staining pattern, which is associated with myeloperoxidase. These are important to recognize because commercial laboratories can test for ANCA by these two different methodologies: the indirect immunofluorescence looking for CRP ANCA, or target antigen-specific testing done by ELISA, which looks directly for antibodies directed against proteinase 3 or myeloperoxidase. Now, what is positive by one testing method may not be positive by another. So when we think about C-ANCA, our vasculitic diseases of GPA, MPA, and EGPA, we would expect to see a concordant match of a positive C-ANCA with a positive anti-proteinase 3. But there are case reports of associations where patients may have a positive C-ANCA and a negative anti-proteinase 3, most prominently including in infections such as tuberculosis and endocarditis, which can be most important in differentiating from vasculitis. This is even more significant when we talk about P-ANCA, where again our vasculitic diseases would be expected to have a match between a positive P-ANCA and a positive anti-NPO. But our gastroenterology colleagues are very familiar with P-ANCA, as this can be seen in association with inflammatory bowel disease, where we may see a positive P-ANCA, but would expect to see a negative anti-NPO. And this can also be seen in the setting of other autoimmune diseases, infections, and medications. This highlights that a positive ANCA that is done by immunofluorescence should be confirmed by antigen-specific proteinase 3 or myeloperoxidase ELISA in order to optimally know how to interpret these results. The key clinical issues regarding ANCA: one is whether ANCA can be used to diagnose granulomatosis with polyangiitis, which was the issue raised by our case. And this really depends upon the clinical presentation. So when a patient has sinus, lung involvement, and renal involvement, the predictive value of a positive proteinase 3 C-ANCA is 90%, which would make it similar to biopsy. However, in a patient who has only sinus and lung involvement, as was in our case, the predictive value would be down to 30 to 60% because of the potential for infections and malignancies, which are more common. And so because of that, biopsy often remains indicated depending upon the clinical scenario. The other question is whether high levels of ANCA indicate active vasculitis. And the answer is no. The levels are higher overall in people with active disease, but are not reliable at the level of the individual patient in assessing disease activity, and should not be used alone in guiding treatment or reinitiating treatment. So the diagnosis of granulomatosis with polyangiitis: a positive anti-proteinase 3 C-ANCA can be found in about 75 to 90% of patients, whereas about 5 to 20% may have a positive myeloperoxidase P-ANCA, and up to 20% may be ANCA negative. And as we discussed, this can suggest GPA, but generally should not be used solely for diagnosis. Sinus and lung biopsies may reveal evidence of necrosis, granulomatous inflammation, small vessel vasculitis, where again, surgical lung biopsies in radiographically abnormal lungs have the highest yield. Kidney biopsy shows a focal segmental crescentic necrotizing glomerulonephritis that has few to no immune complexes, or so-called post-immune glomerulonephritis. And this differentiates it from what would be seen on a biopsy in lupus, post-streptococcal GM, or antiglomerular basement membrane disease. The treatment of granulomatosis with polyangiitis for severe disease would be glucocorticoids combined with either cyclophosphamide or rituximab. When cyclophosphamide is used, it is given for 3 to 6 months and then transitioned to either rituximab or azathioprine or methotrexate. Rituximab has been found to be as effective as cyclophosphamide and represents an option for severe induction. Now, another thing to be aware of is the C5 receptor antagonist, avacopan, which has been found to be able to reduce glucocorticoid exposure in patients with severe disease and is FDA approved for this indication. For non-severe disease, prednisone in combination with methotrexate, mycophenolate, or rituximab has been used. For untreated disease, this is a very severe disease in which the median survival time is really only 5 months, with mortality occurring from pulmonary or renal failure. However, with effective treatment, there is over an 80% survival rate that occurs, with the main issue being relapse, which can occur in up to 50% or 50 to 70% in those patients, even despite effective remission induction. Our next case is that of a 55-year-old man who presents to the emergency room with purpura and a new foot drop. He has no nasal symptoms, cough, or gross hematuria. Exam shows palpable purpura and an inability to raise his foot. Nasal mucosa is normal, his chest is clear, and he has no synovitis. Microscopic polyangiitis is in your differential. Which of the following would not be helpful in supporting this diagnosis? A, ANCA, B, sural nerve biopsy, C, chest radiograph, D, urinalysis, or E, hand x-rays. And the answer I'm looking for here is hand x-rays. Now, an ANCA would be very important to do in this patient. You could also consider a sural nerve biopsy, as he does have a foot drop. A chest radiograph should be pursued in all patients where small vessel vasculitis is being considered, even in the absence of features, as should a urinalysis. And hand x-rays would not be useful here, even though he has arthralgias, as the joint features that occur in vasculitis are not associated with any features of joint destruction. So microscopic polyangiitis is a vasculitis of small vessels with few to no immune complexes, which was separated from polyarteritis nodosa in 1994, as we had previously discussed. It has many similarities to granulomatosis with polyangiitis in being a small vessel disease that is ANCA associated and in which we can see features of pulmonary hemorrhage and glomerulonephritis. It differs from GPA in lacking granulomatous inflammation, so we do not see any disease of the upper airways, ear, nose, and throat region. This is very much a disease that is within the spectrum of the pulmonary renal diseases, in which we can see alveolar hemorrhage and glomerulonephritis, but there are also prominent sites of involvement, particularly including the nerve and the skin. In diagnosing microscopic polyangiitis, in contrast to what we talked about with granulomatosis with polyangiitis, this is predominantly an anti-myeloperoxidase P-ANCA associated disease in which we can see this present in 50 to 80% of patients. We can also see 5 to 10% that have proteinase 3C ANCA, and again, up to 20% may be ANCA negative. And once again, this can suggest MPA, but alone should generally not be used for diagnosis. Lung biopsies will typically show small vessel vascularitis, such as capillaritis, and the renal lesion of microscopic polyangiitis is identical to that of granulomatosis with polyangiitis and being a posse-immune glomerulonephritis. The treatment approach to MPA is similarly to what we discussed with GPA in the management of severe disease, being glucocorticoids in combination with either cyclophosphamide or rituximab, with the availability of avacopan. And for non-severe disease, prednisone and methotrexate is an option. Like granulomatosis with polyangiitis, microscopic polyangiitis has a poor outcome if untreated. Once again, from mortality from pulmonary or renal failure, there's a 75% 5-year survival with treatment, and relapse occurs in about 35% of these patients. So which of the following is not a characteristic feature of eosinophilic granulomatosis with polyangiitis Church-Strauss? Is it A, asthma, B, eosinophilia, C, granulomatous inflammation, D, cardiac disease, or E, neutropenia? And the answer I'm looking for here is neutropenia. Asthma, eosinophilia, and granulomatosis inflammation are all features of EGPA, and cardiac disease is actually the most prominent source of mortality. Neutropenia is not a feature that occurs in primary vasculitis. The features in the CBC reflect that of acute inflammation, where we would typically expect to see an elevated blood count rather than decrease. So if you see neutropenia, if this is the diagnosis, there is another cause that is occurring in this setting. So EGPA, formerly called Churg-Strauss syndrome, is a vasculitis of the small to medium-sized vessels associated with eosinophilic and granulomatous inflammation of the respiratory tract. This is a very uncommon disease. It affects about 3 people per million and affects men and women equally. EGPA is thought of as having 3 phases, which is very helpful conceptually, but is not seen in all patients and may not occur in sequence. There is a prodromal phase in which we can see asthma, which is often adult onset, and allergic rhinitis. The eosinophilic phase in which we see peripheral eosinophilia and eosinophilic tissue infiltrates. And the vasculitic phase in which vasculitis involving the nerve, skin, lung, GI tract, heart, or other organs may occur. Now, although this is considered within the family of ANCA-associated vasculitis, ANCA is in fact seen in less than 40% of these patients, and when present is usually a myeloperoxidase P ANCA. Biopsies can reveal eosinophilic tissue infiltrates, granuloma, and small vessel vasculitis, but these are often difficult to demonstrate, such that the diagnosis is often based on clinical features, typically including asthma, hypereosinophilia, and clinical manifestations consistent with vasculitis. The treatment of EGPA, prednisone alone, could be used in many instances, and for severe disease, such as that affecting the glomerulus or pulmonary hemorrhage, would consist of prednisone and cyclophosphamide. Mepolizumab, an IL-5 antagonist, has been found to be of benefit in randomized trial and is approved by the FDA for this indication, but it should not be used for severe EGPA, as these patients were excluded from the clinical trial. The prognosis of EGPA is influenced by factors of severe disease, such as those affecting the GI tract, kidney, heart, or central nervous system. And as noted, cardiac involvement is the main cause of patient mortality. Vasculitic relapses occur in about 26% of these patients, but relapses of asthma are frequent and may limit the ability to taper prednisone. Which of the following viral infections is associated with cryoglobulonemic vasculitis? Is it A, varicella zoster, B, human immunodeficiency virus, C, parvovirus, D, hepatitis C, or E, hepatitis B? And the answer I'm looking for here is hepatitis C. Varicella zoster can be associated with central nervous system vasculitis. Human immunodeficiency virus and parvovirus have associations with rheumatic disease. Hepatitis B is associated with polyarteritis nodosa, but the main association with cryoglobulonemic vasculitis is hepatitis C. Cryoglobulonemic vasculitis is a small vessel vasculitis with cryoglobulin immune deposits, where cryoglobulin is cold, precipitable, monoclonal, or polyclonal immunoglobulins. This can occur in conjunction with a variety of disease processes, including multiple myeloma, where it was first described, lymphoid neoplasms, chronic bacterial infection, and connective tissue diseases. And as noted, over 80% of cryoglobulonemic vasculitis is related to hepatitis C. The clinical features of cryoglobulonemic vasculitis: purpura, arthritis, neuropathy, or glomerulonephritis. This occurs in up to 50% of patients, where we may see proteinuria, hematuria, but in contrast to what we talked about with GPA or MPA, this is rarely rapidly progressive. And the histologic lesion here is that of a membranoproliferative immune complex glomerulonephritis. The diagnosis of cryoglobulonemic vasculitis is usually a clinical one that combines compatible clinical features, laboratory features supportive of cryoglobulinemia, and where possible, identification of an underlying cause. The laboratories we should seek out include positive cryoglobulins, although these are difficult to measure, a positive rheumatoid factor, which illustrates that not all positive rheumatoid factor is related to rheumatoid arthritis, a positive hepatitis C, and if negative, a search for other causes, and hypocomplementemia, as this is an immune complex process which will drive down complement levels. Biopsies may be useful in selected settings. To treat underlying process, hepatitis C, when it's associated, should be treated with antiviral therapy. Immunosuppressive therapy may be needed to gain immediate control of the vasculitis, but there has been anecdotal experience only and may increase hepatitis C viremia. Plasmapheresis has been associated with brief responses, but is not a long-term option. And rituximab anti-CD20 has had data supporting a role, particularly in patients with hepatitis C-associated disease. The outcome in hepatitis C-associated cryoglobulinemic vasculitis is improvement in the vasculitis is associated with the clearance of viremia, with relapse typically occurring if there is a return of viremia, which is less common with our current antiviral agents, and mortality is typically due to non-vasculitic sequela. Now, cutaneous vasculitis represents the most common vascular manifestation that we will see in clinical practice. In less than 30% of these patients, there is no identified underlying cause or evidence of vasculitis in other organs, such that the disease is isolated to the skin. However, in the remaining 70+% of these patients, this occurs in the setting of an underlying process, such as a medication, infection, malignancy, connective tissue disease, or a heralding feature of a primary systemic vasculitis. This case is of a 55-year-old male who's referred to you from an urgent care clinic where he was seen 3 weeks ago for palpable purpura. The purpura are painless and he otherwise feels well. He brings copies of labs performed by the urgent care, which reveal a white blood count of 8.9, hemoglobin of 12.0, platelets of 211,000, sedimentation rate of 30, and his urinalysis shows 1+ protein and 20 to 30 red blood cells. Which of the following studies should you order next? A, urine culture, B, ANCA, C, creatinine, D, cryoglobulins, or E, prostate-specific antigen? And the answer I was looking for here was creatinine. So of concern is this patient is bringing in today laboratories that show evidence of microscopic hematuria that were drawn 3 weeks ago. And we have no idea where this patient's renal function is. As this will not cause the patient any symptoms, we need to know the creatinine immediately to assure this patient is not in impending renal failure. These other tests you certainly may want to consider further down the line, but the most immediate urgency is to know his renal function today. So you see a patient with possible cutaneous vasculitis. What is it that you need to do? You need to recognize if a patient is in a potentially threatening situation, as was illustrated in the case. We want to confirm that this is vasculitis, and then to determine if there is an underlying cause for the vasculitis. So how do you do this? Well, like any other problem in internal medicine, we look at the evidence that we are presented with. And what we can see when we look at the organ systems that can be affected by vasculitis is that a vast majority of clues we can obtain from doing a good history and physical examination. But what we can also see is that there are certain sites, such as the lung and the kidney, where there may not be evidence unless we dig further in further investigation, particularly in our labs and imaging. So as we do a history, we want to do a complete review of systems, looking for evidence of sites of involvement or features that might suggest an underlying cause, and in particular, review their medication list, which should include over-the-counter agents, supplements, or recreational drugs. On examination, we want to perform a thorough exam, which again is looking for clues that might suggest sites of organ involvement or features of an underlying disease. In terms of our labs, our most basic labs are in many ways our most important. Urinalysis is important, and if blood is present, we want to make sure that we know the creatinine immediately. We want chemistries to look at renal and hepatic function, blood counts with differential, and marker of inflammation, such as the sedimentation rate and/or C-reactive protein. And then you will pursue additional lab testing if there are features that point towards a systemic vasculitis, other rheumatic or inflammatory disease, infection, or neoplasm. In terms of imaging, chest imaging should be performed in all patients with pulmonary symptoms, but even in the absence of pulmonary symptoms, you will want to obtain imaging if there are other features that suggest a systemic small vessel vasculitis, as asymptomatic radiographic features can occur in up to 1/3 of these patients. And you will then pursue computed tomography, magnetic resonance, or arteriography of other sites as is clinically indicated. Biopsies should usually include cultures and/or immunofluorescence, recognizing that lesions that look like vasculitis may not be. And we want to keep in mind the differential, which includes not only our primary and secondary vasculitides, but other diseases that may have similar features that mimic vasculitis. In particular, these can include infections such as endocarditis, neoplasms or lymphoproliferative diseases, other granulomatous diseases such as sarcoidosis or mycobacterial infections, when the kidney is affected, other causes of glomerulonephritis, and then there are features of cholesterol emboli and atrial myxomas, which can mimic vasculitis. So in summary, vasculitis represents blood vessel inflammation, where organ injury occurs from vessel occlusion or thinning. Suspicion of vasculitis is the key, where we're looking for features that might suggest purpura, mononeuritis multiplex, pulmonary hemorrhage, or glomerulonephritis, but also thinking about this in unexplained multi-system disease, such as a patient with worsened sinus disease, unresponsive to treatment, and do remember potentially serious and asymptomatic disease affecting the kidney or lung when present. You want to characterize where possible to a specific vasculitic disease. So you may already be thinking that this is giant cell arteritis or granulomatosis with polyangiitis. But when not, examine the pattern of clinical features and laboratory abnormalities. And think about the predominant size of vessel that's being affected, as this may guide you towards the diagnosis. You then want to pursue the diagnosis, which is usually by biopsy or arteriogram, and then treat based upon the type of vasculitic disease and its severity. So with that, I would like to thank you and good luck on your examinations.
Thank you, Dr. Langford. That was an excellent talk. So this concludes the rheumatology section of the board review course. Wish you all the best for your boards, and rheumatology continues to be a very important part of what you'll be expected to be asked during the boards. I will be handing over the mic to Dr. Tallahassee for the rest of the announcement. Yep. Sure.
Thank you, Dr. Chatterjee, for the moderating the rheumatology session. So that completes this morning session. So please do not forget to evaluate all the speakers, as you can see from the QR code on the presentation. Because we have finished almost 25 minutes earlier, we are going to move the afternoon session to start at 1 p.m. Again, 1300 hours, and have a good lunch, and we will see you in the afternoon. Thank you.
Evaluation.